In this slide, we will be discussing Chapter 5, Managed Care Plans. The purpose of a managed care plan is to provide affordable, high-quality health care. Managed care systems, they merge clinical, financial, and administrative processes in order to manage the access, the cost, and the quality of health care. The purpose of a managed care plan is to provide affordable, yet high-quality health care. Managed care traces its origins back to the early 1900s. As early as 1910, the Western Clinic in Tacoma, Washington, offered its members services for 50 cents per month. The first Blue Cross plan in Dallas, Texas, was a form of managed care. In the 80s and 90s, there was a lot of economic constraints that encouraged the growth of HMOs and other types of managed care plans as employers sought out to reduce the costs that they were putting towards health care. Continued growth of hybrid models did grow and flourish during the 80s and 90s as consumers still had the desire to choose where they went to the doctor and if they saw a specialist or not. So as a result of those things, there are numerous types of managed care plans in the U.S. today. Managed care organizations, or MCOs, are healthcare plans that attempt to manage care. Some of the services are listed on this slide. Really, the MCOs are going to offer different levels of services depending on the cost of the premiums and the co-payment. So the items on this slide are typical services that are provided by MCOs. Managed care organizations do share characteristics associated with providing quality of health care and cost-effective. The line between quality care and cost-effective care does blur considerably. And the characteristics for managed care are not unique just to managed care. Other insurance plans do implement a lot of these items as well. MCOs stress the use of criteria in their selection of providers. They look at quality, cost, location of the providers that they elect to have contracts with. Managed care organizations emphasize the health of entire populations of members. We talk about that risk pool again. We want all members to remain healthy, so the risk pool is healthier and therefore our costs are less. We look at evidence-based clinical practice guidelines for both the health of populations and our care management tool. Those are guidelines set forth, so no matter where you go to the doctor, you will receive the same services, the same tests. So if you're a new diabetic, if you go to hospital A, B, or C, they will all have the same protocol of care, the same lab tests at the same point, that type of thing. MCOs also participate in rigorous accreditation processes and in performance improvement initiatives. They also look at satisfaction of the members by offering them surveys. MCOs implement various forms of cost control. These cost controls include service management tools, the method of reimbursement, and financial incentives. Several cost controls are related to medical necessity and utilization. These cost controls contain and monitor the use of healthcare services by evaluating the need for and the intensity of service prior to it being provided. Utilization review assesses the appropriateness of the setting for the healthcare service in the continuum of care. Also factored in are the patient's severity of illness and any other conditions that they may have. The gatekeeper role of a primary care provider is cost control. As the coordinator of all healthcare services, the primary care provider can determine if a referral is actually needed. So think of the primary care provider as the gatekeeper, opening that gate and allowing the patient to see a specialist that would in turn cost more money. Prior approval, that is basically an administrative process for obtaining prior approval for healthcare services. You may hear that also called pre-authorization, pre-certification, pre-admission review. Those are other terms. Basically, they all mean getting approval before a service is rendered. Second and third opinions. This is basically, as it says, an opinion from a medical expert. And they would do that if something was a test or a surgery was really high risk or really high cost. Utilization review looks at two questions. Should this healthcare service occur? If yes, it should. Then in what setting would it be the most effective? Case management coordinates an individual's care in high cost or very complex cases. They would then be assigned a case manager who would help monitor their care. That would generally be a physician or a nurse. Prescription management basically looks at managing all the patient's medications, making sure the patient is educated on their medications, that there is no drug-to-drug interactions or food-to-drug interactions. MCOs utilize episode of care reimbursement. That is different than what traditional insurance companies offer is fee for service. You have a service, a fee is generated. Episode of care follows capitated reimbursement or global. Capitation, this is when a provider is reimbursed a predetermined fixed amount per member per month. So no matter how much service is actually rendered to the patient, they will just get a set dollar amount per month. In global payment, this is where the network would receive a fixed amount for all the members in that managed care organization. That a single payment would be divided among the providers. Financial incentives exist for both providers and members in MCOs. For providers, the incentives involve the provision of cost-efficient care. So the types of services that are the focus of incentives are listed on the slide here. Contract management is basically when a provider looks at what they have been providing to patients and what they're actually spending based on what they're getting reimbursed. If they need to look at that contract and renegotiate, they would do so. Carve-outs are basically getting an extra payment outside of that capitation for those populations or those patients that are very sick, have very complex cases. They are costing more money, so they would carve out an additional payment for those. As managed care has evolved, the lines have blurred among the types of managed care organizations. The different types of managed care organizations can be placed on a continuum of control. So the HMOs represent the most controlled and the PPOs represent the least controlled. Health Maintenance Organization, the HMO Act of 1973, was the first initiative to try and control healthcare costs. Subsequent amendments were enacted. The conditions were the first HMO, a minimum benefit package, open enrollment, and community rating. In the community rating, The rates for healthcare premiums are determined by a geographic area rather than by age, health status, or company size. So we'll talk about the different types. The staff model is the HMO where it provides hospitalization and physician services through its own staff. It owns the facility. The physicians are employees and are paid a salary. This can also be called a closed panel, the staff model. The group practice model, this is where the HMO contracts with a medical group. So in this, the medical group would have the risk because their payment is that per member per month generally, so they will have the risk if patients overutilize services. In the network model, that is the same as the group HMO, except the network model will contract with 2 or more physician practices. The IPA, or the Independent Practice Association, that's a type of MCO where participating physicians maintain their private practices. So the IPA would then contract with individual providers. The HMO reimburses the IPA on a capitated basis. A preferred provider organization, or PPO, is an entity that contracts with employers and insureds to render healthcare services to a group of members. It's common to have the characteristics that it's decentralized, there is flexibility of choice for the members, negotiated fees, generally discounts, financial incentives for the members to choose a preferred option. They're not as regulated as HMOs, and there is limited financial risk for the provider. In a point of service plan, that is where a member can choose how to receive services at the time they need them. Generally, members can choose at point of service whether they want an HMO, a PPO, or a fee-for-service plan. They need to make that decision during the open enrollment period for their health plan. An EPO is a managed care organization that is sponsored by self-insured or self-funded employers or association. An EPO is very much a hybrid along the continuum of freedom of choice. EPOs have features of both HMOs and PPOs. They have a small network of primary care physicians that act as gatekeepers, and they also reimburse providers based on a discounted fee schedules like PPOs. EPOs do not reimburse providers through capitation. CHIP is the Medicaid and Managed Care State Children's Health Insurance Program. It's a joint and federal state program that varies from state to state. Each state can set up their own stipulations and regulations. CHIP accounts for care for almost 25% of the U.S. population. Medicare Advantage, or MA, is a form of a managed care organization that is for Medicare beneficiaries. They have deductibles and copays that are lower than other HMOs or MCOs. They may incorporate case and disease management in order to help control costs. The Special Needs Plan is also a form of Medicare Advantage, and it was established by the Medicare Prescription Drug Improvement and Modernization Act of 2003. There are 3 types of different groups. Dual eligible, if they were also eligible for another Medicare plan, for those beneficiaries that are institutionalized, and for those with chronic medical conditions. An integrated delivery system is a collaborative integration of healthcare providers that deliver care to a population across the continuum of care. And let's see, the terms that you may hear that called are listed below. They all mean an integrated delivery system. There are 4 different types of IDSs. Hospital-led, that is the most common. Physician-led, physician-hospital organization, and insurance-led. There are also different models. The IPO includes 1 or more hospitals, a large physician group practice, other healthcare organization, or a configuration of all of those. The group practice without walls is a practice where they've maintained their separate practices or their separate offices in a geographic area. The physician hospital organization, that's an entity that's formed by a hospital and a group of physicians. And management service organization, that's an entity that provides management services, administrative, and information systems to 1 or more physician group practices or hospitals. A medical foundation is a nonprofit service organization. Members generally include physicians, other healthcare providers. They are geographically based in certain areas. Generally, there's freedom of choice and preservation of that physician-patient relationship. Some purposes include medical education, PPOs, MSOs, or peer review and quality improvement organization. As we look at trends in the future, we will probably see more managed care organizations or the concepts of managed care to help improve access to our vulnerable population. We want to be sure that everyone in the U.S. has access to health care, no matter what their circumstances are.